Yes, ma'am.
Yes. A very good afternoon to each one of you. On behalf of IMA Bangalore branch and AstraZeneca Pharma Private Limited, I welcome each one of you to this afternoon webinar. Today is a landmark for us because of two things. One is the Women's Wing Bangalore branch has kick-started its webinar series, and today is the first of the series focused on women's health. And another important landmark is we are in the amidst the celebration of Dr. B.C. Roy's birth and death anniversary. So as a tribute to Dr. B.C. Roy, we are again joining hands with his mission, and one of his missions was women health, and so now our focus is on women health. And to speak to us more about women health, in particular about malignancy, cancer in women, how best we could take care of ourselves much before the malignancy sets in, and if in case once it sets in, how best we can take care of ourselves. I mean not only us but also our patients. And to give us more information, we have stalwart in our field, Dr. Ima Bb, who is going to give us in general more information about malignancy in women. And in particular, Dr. Smita Saldana is going to give us more information of cancer in malignancy in ovary. So before we start off, I would request Dr. Anuradha, medical officer at KC General Hospital, a very active Bangalore branch women doctor wing member, to give to say IMA prayer. I request all of you to stand while she is reciting the prayer. Anu, wait ಮಾಡ್ತಾ ಇದ್ದೀವಿ. Take your time.
Dr. Anuradha, madam.
Yeah, another Dr. Anuradha.
Yeah.
Madam, can you hear me?
Yes.
Now? Okay.
Yes, you can start. Video no on ಮಾಡ್ಕೊಂಡಿದ್ದೀರಾ?
Yeah.
Yes.
Yes. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. May everybody be happy, may everybody be healthy, may everybody be free from pain, may everybody be free from sorrow, may we be the healing cure beyond every greed and blur. Thank you, madam. Thank you.
Thank you. Thank you. So we now move on to the main webinar, and before we start off with our webinar, let's maintain 1 minute silence in paying respect to the departed Dr. Matias, as well as the our non-doctor colleagues and the public. So let's stand for a minute. Thank you, one and all. So we are now starting with our webinar. Whenever I see a patient, it always comes to my mind, let's suppose you see a patient with CA breast or any malignancy for that matter. What best could I have done to the same person, same patient, if when she had come to me a year or two back? Always, that is always runs in my mind. So let us now listen to Dr. Ima Divakar, because we are focused on coming to know as to how better we can perform at our clinic, keeping prevention of malignancy in mind. And to introduce Dr. Ima Divakar, we have our very active Women Doctors Wing member, Dr. Hema. She is a consultant ophthalmologist and retina specialist, and she is going to introduce Dr. Hema Divakar.
Thank you, ma'am. Thank you, Dr. Anuradha, ma'am. It's my privilege to introduce Dr. Hema Divakar, because I worked with her also and the same department being ophthalmology. So I welcome you, ma'am, for this webinar. Coming to the affiliations and the organizational positions, Madam is a medical director of Divakar Specialty Hospital, CEO chairman of ARTIST, that is an Asian Research and Training Institute for Skill Transfer, Dean KCOG, Vice Chair for FIGO Committee 2015 till date, National Technical Lead FOGS, Manyata Delivering Quality Healthcare and Capacity Building. Madam also had chaired as a past president of FOGSI, that is Federation of Obstetrics and Gynecology Society of India, that is 2013. An opinion leader, an influencer for social and legal issues related to women's health. And there are many awards and recognitions, the main things being the FIGO Women Achiever Award, that is 2015, 2018 Global Asian of the Year, Excellence in Women's Healthcare and Social Entrepreneurship Award, CME Excellence Award for Artist, and CSR Times Award for Divakar Service Trust. These are some of the brief introduction about Dr. Hema Divakar. She is a senior consultant and a past president of FOGSI. And now the topic of talk is cancer in women, awareness to action. So with this a brief introduction, I would like to introduce Madam Dr. Hema Divakar. It's our privilege for Madam to be in our seminar. So welcome, ma'am. Over to Dr. Hema Divakar. Thank you.
Thank you, Hema. Yeah. Can you hear me?
Yes.
Ellarigu namaskara. Being an ophthalmologist, you have seen Hema through Hema's eyes. Thank you for the kind introduction. And my very beloved friend and colleague, Dr. Anuradha, when she sent an invite, I did not look at when, what, how, where. If it is Anu, it has to be yes. That was how I am a part of this fine afternoon. And we're very proud of women from the WDW IMA branch of Bengaluru who have stepped forward for action. Because, ladies and gentlemen, we strongly believe just knowing is not enough. The gap between the knowing and the doing has to be bridged. That is very, very crucial. And my heartfelt thanks to Dr. Vinay, Mamta, Satyavati, and of course, Hemlata, besides Anu, who has so kindly invited me. Permit me a moment to share my slide. So, we being routine OBGYNs are not experts like Dr. Smita in the field of cancer management, but like anybody from the IMA, anybody from any circuit of the medical fraternity, to prevent and detect early. That is the key, and we need.
John, I think you can mute.
So anybody who is involved in the patient care, the awareness is both to the lay public out there and also to the peer group, as how we are going to be discussing today. So the key issues that I'm going to discuss, because Smita is the next distinguished speaker, is going to speak about the ovarian cancer. So I will restrict in the limited time my talk to what is so very preventable, which all of us should know and should take action. That is the issue of cervical cancer. What can help if we self-examine and detect early? That's all about the breast cancer. And of course, in the female reproductive organs, the leftovers are the endometrium and the ovaries. Ovary going to be addressed very shortly. So very briefly, I'll touch upon the endometrium cancer as well. So much to speak about awareness. Once when I was on a talk show, and then I was asking somebody, are you aware of something called the cervical cancer? Do you know what's a cervix? And there were many, not one, but at least 4 or 5 women out there said, yes, doctor, we all have had cervical spondylosis. So we know what a cervix. So they couldn't even, relate to the fact that the neck of the uterus alludes to what we call as cervix in our medical parlance. So dear friends, the awareness starts right from there, because it is not an organ that they can see and relate to. Many women will know garbhachila or the uterus, but they may not necessarily know what the cervix is. So the education and economic status also makes a huge difference in seeking care even after they're aware. And in countries like ours, we need to be very cautious about the fact of the gender inequity, because of women, oftentimes even in the nutritional spheres, we say that she eats least and she eats last, and she really doesn't bother to take care of herself, or seldom she's hesitant to tell her family members what she's going through. And as Anu said, they push it as far ahead as possible, and always a thought in the clinician's mind is, I have missed the bus. Could I have seen her earlier, and could I have done any better? So coming to the cervical cancer, luckily the scientific breakthrough has told us that HPV, or human papilloma virus, that's the one and only cause of the cervical cancer. That means there can be no cervical cancer without the infection with the human papilloma virus. And we often tell the patients that just like polio is caused by polio virus, and then you take the polio drops and then you get rid of it, HPV is the single most causative reason for the cervical cancer. And of course, it has lots of cousins in its groups, the high risk and the low risk category, out of which what we have bracketed here, the 16 and 18, these are the most potentially notorious ones, okay, who are responsible for more than 90% of the cervical cancer. So how does this all happen, and how long does it take? So here are normal cervical cells. So I told you that unless they're infected by the HPV virus, there can't be a cervical cancer. It's not as if they're infected today and tomorrow or within a few weeks they will turn into cancer. No, they will take at least a decade, maybe over 10 years, to slowly, if it persists, if this infection persists, it will make the cell structure change into precancerous, slowly, very slowly, tortoise snail pace as we call it, progress into cervical cancer. So we have time from the time of infection, which can of course clear out of its own. It's like having repeated tonsillitis. You get the tonsillitis, you also get cured of that, and again you can potentially get reinfected. Similarly, it's a sexually transmitted virus, on and off. And one unfortunate time, if it stays there, the body, if it cannot get rid of the HPV virus, slowly over the years, it will turn into the cervical cancer. So best is to stop the entry itself. If you vaccinate the young girls 10 to 12 years old, the normal cells will remain normal cells, because entry of this HPV will have a barrier with the vaccines that will fight it out. The second opportunity is the screening. You have to take a sample of these cells and find out if they're still normal cells, or if they have HPV infection, or have they turned into precancerous cells, or do the cells show a frank cancer. So this is the process. So as I said, vaccination of young adolescents is the one which prevents, and the screening, the earlier you find out, even in the precancerous stage, or it's tending towards cancer, then you can still do away with the entire uterus, cervix, and do a extended surgery and deroot it from the body. No women should ever die of cervical cancer. That is the campaign, and we want, like how the polio has been eliminated, we want to eliminate the HPV by a mass vaccination program, so that in the Western world, they're hoping 2030, they'll be able to get rid of the HPV infection per se, whereas countries like ours may perhaps take a little more time. But even in the terms of screening and reducing the death rate by early pickup and early action, from awareness to action, we can certainly do a lot more better. How many women we need to screen? Of course, the entire population who is sexually active. Anytime between 16, 18 years to the menopause, every 3 years, the screening should go on. So 100% would be the right answer. But how many are we actually screening in our country? Less than about 5 to 7%. So we are aware, but it is still calling for a lot more action. So how do you detect these HPV viruses? Well, this is the whole sequence of events. Women who have had sex with HPV-infected men, within weeks to months, they will develop if they have developed the HR or high-risk HPV infection, within some months, if it stays there, they will develop what is called a persistent high-risk HPV infection. If this persists long enough, then they will develop high-grade cervical lesions, which will go on to become cancer cervix. So again, please do recall and remember that we have so much time and opportunity from awareness to action. So how do we check on this? Well, the old-time testing is the pap smear or the cytology. We actually have to take the cells out there, study it under the microscope, see if they're normal, see if they're precancerous, see if they've already turned into cancerous. Another way is the environment infected with HPV. So this is the new era test. Sometimes the pap smear can miss, whereas the HPV, it gives us a yes or no answer. It has a very, very high degree of sensitivity. So slowly, the screening methodologies are turning from just a visual inspection, just see the cervix with a speculum examination. It's not looking normal. It is angry red. It's got some lesions. Well, that is your yes or no answer already. This is the very basic VIA, as it's called, visual inspection. The next thing is the cytology. Just scrape the cells, send it for testing, and you figure out whether the cells are normal or not. The last and the best thing, which is now recommended as the sole primary screening test, is the HPV testing itself. And if the HPV comes positive, then you back it up with a cytology to enhance the detection rate. So LBC is liquid-based cytology. That is one of the way we do the pap smear. We can also opt to do the HPV PCR test alone, or you can do a co-testing, a combination of both. If the patient is young, it's good enough if you just do the HPV test and leave it there, because you'll be still missing about 3 out of 25 patients. So in a huge cohort, they've found 14,000 patients who would be best. But if you combine the tests, that is, first you do a HPV, if it's positive, then you do the cytology, then there are very few patients who could be missed. So a combination test, if the first test is positive, follow it up with cytology. So just look at from awareness to action. If you haven't bridged the gap, this is the data from the West. In 2012, 8 million people who were not screened for 5 years. So some of their cervical cells surely would be precancerous or cancerous. Then 7 out of 10 women who had not been screened had a regular doctor's checkup. Not that they didn't come to the doctor, They came, but we didn't use that opportunity to screen. And because we did not screen, we missed out the diagnosis on a significant number of patients. So if screening is enough, then why vaccinate? That's the next question that anybody would ask. Just look at the data here again. If you only vaccinate, the vaccines available today in the whole group of the cousins that I showed of HPV, the two main runners are 16 and 18. Yes, vaccine is available against 16 and 18, but there are a bunch of other little different numbers of HPV viruses. The vaccine is available only against 9 of them. So even if you vaccinate, if you do not screen, you will still miss a small percentage. So half the number are certainly covered, but if you use a combination of the vaccination and still screen, you will significantly pick up each and every case and really not miss many cases. So that is the importance of primary prevention of vaccination. You please ask each and every one of your young girls and young women whether they're vaccinated or not. That's, of course, the first action step that each one of us have to take. And the follow-up screening every 3 years, most likely that because the HPV infection itself is prevented, you'll have less and less numbers with the abnormal cells. But even if you do have them, you'll be able to detect them early and take action. So cervical cancer is the only type of HPV cancer for which there is a recommended screening test. Pre-cancer for other HPV-related cancers may require invasive testing and treatment because HPV is a virus which is 100% responsible for cervical cancer, but it can also cause oral cancer, anal cancers, and so on. So 90% of HPV cancers, no matter wherever the infection is, primary focus, we are focusing on talking about cervix. But if there is anal cancer or vulval cancer or oral cancer because of HPV, 90% of them are also preventable. So once you give the vaccine, there is a whole range of HPV-related cancers that you will be able to control. So today is an era where we are talking about vaccinations. Polio, I already mentioned. COVID-19, we're desperate to procure the vaccine and give it to everybody. But look at this. The HPV vaccine, it has been available. We are aware of that. Have we acted upon mass immunization of all our girls and women in the quest that we will prevent cervical cancer? The answer is quite clearly no, because hardly 15% of our girls and women in our own country have received the HPV vaccination so far. HPV, just like COVID, does not discriminate by age, or neither does the vaccination discriminate by age. In India, 60,000 women lose their lives to cervical cancer every year. Believe me, each and every one of those 60,000 deaths could have been prevented by vaccination and screening for sure. Women remain at risk for acquiring HPV infections throughout their lifetime. As I said, HPV comes and HPV goes. Again, it comes, again, it goes. But if it comes and it stays, then it will move on to cancer. As per majority of cervical cancer patients, they are in the age group of 40 plus. So between 20 and 40, there is enough time for you to see what kind of cells changes are occurring, and of course, enough time for you to vaccinate. So 9 to 45 years is the recommended age for cervical cancer prevention as in the vaccines, and they have proven efficacious even in the mid-adult women, because even if it's a precancerous, it will just arrest it there. It will then reduce the viral load so that the cancer cannot progress, and that in itself changes the prognostic value. Again, this vaccine has been globally acknowledged vaccine. It's a result of many, many years of research and development, not few months, but many years, rigorous studies, and 0 breakthrough cases have been reported in the last 14 years of follow-up after giving the vaccine. So safety of the vaccines has been reiterated by renowned global organizations, inclusive of the WHO. And here you will see inclusive of FIGO, FOXY, all those ABCD, which Hemlata read out. All the organizations have endorsed that HPV vaccine is here to stay, and more than 300 million doses have been given worldwide in the last couple of years. So vaccine hesitancy is more in the provider's mind than in the ones who actually take the vaccine. So from awareness to action, let us move for making the HPV vaccination available, especially to adolescent girls. Why? Because there are 4 main reasons. Higher immune response in adolescents versus the young adults. Immunizing before the exposure can give the highest possible efficacy. Why? Because before the sexual activity, if you give this at the age of 10, 11, 12, for which the vaccination has been approved, the huge immune response mounted, the HPV virus is not even allowed an entry into her system. Therefore, that is the best way to protect. And the high risk for acquiring HPV infection is there even with the first male partner. Remember, infected male partner will cause the HPV to enter her system, and it may be the very first one, because multiplicity of partners is blamed for development of cervical cancer. Even if she does not have multiple partners, or the male may have many partners, which is unknown to her, whatever the social circumstances, that before the exposure, if you vaccinate, it's the ideal situation. Cost of immunization, of course, is less in most of the adolescents who need just 2 doses instead of 3. So the recommended vaccination schedule, at least start talking to every parent about this, and every newborn female child, please put this as one of her last vaccines in the childhood vaccination schedule by the age of 10 or 11. That's the time you give the 2 doses. You give the first dose today, and after 6 months, you give the second dose, and that covers for the rest of the lifetime. Suppose, maybe even in the COVID situation, there are so many instances where the second dose has been delayed. So the dictum is, if the vaccine schedule is interrupted, the whole of the course need not be repeated. Maximum 1 year to 4 years interval, you can still give the second dose, which is a booster dose in the adolescents. But if the age is more than 15 and up to 26, then she will require an additional dose at 2 months as well. So 0 dose, 2 months, and 6 months. Because the immune response which a 25-year-old female will mount is far less than what a 12-year-old will mount. So 12 years requires only 2 doses, 1 primary and 1 booster. Whereas if she's 20 or 25, you have to push 1 more additional dose so that to make sure the immune system recalls its memory and the vaccination proves useful. Even beyond 26, even if there is a good chance that already she's in a precancerous stage, it is licensed for use until the age of 45. If very, very likely, as most of our women would have missed the dose, they can still take this up to the age of 45 years, after which, until then, she has escaped of the HPV infection. Very unlikely. I always explain to them that a tubectomy or a sterilization operation or a long-term permanent mode of contraception, we would rather give it to a 25 or a 35-year-old rather than a 55-year-old female. So that's the kind, where the more the age, the lesser the chances. If till then the cells are normal, if till her age of 45 cells are normal, it's likely that it will remain normal, because many times the HPV would have come in and out of her. She has handled it. Her immune system is capable. So after 45, maybe on an individual basis, you may discuss and give it to her, but generally not needed. So the best chance is the earliest chance, 11 to 15 years. After 15 years, until 45 years, with the 3 doses covered, that is the schedule for vaccination. Let's not presume it's too costly. People have paid 10 times, 20 times the cost for remdesivir, oxygen cylinders, this, that, because they have recognized that health is wealth and they need not save their wealth at the cost of their health. So you please motivate them to get there. And I'm sure if the volumes, if the whole of the IMA takes up, and each and every girl and women less than 45, there will be at least 400 million doses that we will need to cover in the next 2 years, then the cost obviously will come down. So make cervical cancer vaccine a part of your routine discussion. Make it a routine for your paramedical staff as well to keep on talking to the patients and train your paramedic staff to tell them a few things and guide them into this phase of awareness and let them decide. And it is the doctors or the healthcare providers many times they feel, oh, it is too costly, how will my patient take? But at least tell her and let her decide. Because we've had, after some television programs, etc., even the street vendors, saving their money and coming for their vaccination. So you don't know what their perceptions and the priorities are. So please make them aware so that they take action. You please be aware so that you will also take a proactive action. So having said this much about cervical cancer, I'm particularly not touching upon once the cervical cancer sets in, what you need to do to deal with it, because most often either a primary vaccination or a screening by pap smear, detection and removal of the cervix, upper half of the vagina, uterus, or extended surgery, if we refer to a gynaecologist. Sad to say that Kidwai Memorial has reported the largest number of very advanced cervical cancers, which could have landed at their doorstep a year or two earlier if they were detected on time. Many of them have gone beyond the stage of surgery, and then radiotherapy and chemotherapy is the only way out. So let's not even talk about that, because we want lesser and lesser and lesser patients in that group, whether rural or urban. Make them aware and guide them for the next action. What are the other cancers in women? You see that cervical cancer was ranking the first in 1982. Now, in the Western countries, at least because of vaccination, etc., it has come down quite a bit. But the breast cancer, which is again the second largest amount of cancer, has now gone up in its ranking. Cervical cancer has reduced, but breast cancer has moved up. But in our country, I must say that all kinds of cancer which could be prevented or detected early are all rampant. And these are just numbers, but every single individual case which could have a preventable or an early detection and ensuring quality of life, we must never, ever miss the chance. So 1 million new cases in the world every year of the breast cancer. That's the topic we are moving on to from the cervical cancer. And it has now become one of the most common malignancies in our country. Of course, the breast and cervical cancer are running neck to neck because we haven't done enough about the cervical cancer issue. And the death rates are higher for these than any other. 1 in 8 women in UK will face breast cancer in their life. And what makes them prone to that? If a woman is older than 50, she's got dense breast, early age of first period, late menopause, long-term hormone therapy, previous cancer diagnosis, like if she has cervical cancer or ovarian cancer, then its oncogenic gene is very much present in her. Relatives with breast cancer, genetic mutations, which will prompt you to diagnose the breast cancer. So we know that someone's chances of developing breast cancer are affected by a combination of the genes and the lifestyle choices and the events throughout their life, like the early menarche and late menopause. There's never a single cause for this disease. Unlike in the cervical cancer, we have only one single cause, HPV virus. That's it. Whereas in breast cancer, there are an array of causes which are unfortunately in combination or a standalone prompt to the development of breast cancer. One more thing about the cervical cancer vaccine, you can give it even to the lactating women. So every single patient who delivers, please guide her throughout her pregnancy about the HPV vaccine, and please urge her to take it before she leaves the hospital. That's what we are also doing both in pregnancy and in lactating women with the COVID vaccine as well. So the signs that a woman has to watch out for breast cancer are whether a lump is felt in the breast or the nipples are inverted, there is a nipple discharge, nipple pain, soreness of nipple in areola, just below her armpit if there is a swelling. All of these will have to alert her to come to the doctor. And one of the key things which we must absolutely not fail to tell any of the patient is the self-examination, because that is the best chance for early pickup and survival. So encourage everyone to be breast aware, and these simple posters, you can put it up in your clinics as well. So they have to check it once a month, 2-3 days after the period. They have to examine the breast and the armpit area, use the finger pads, and both in the up and down direction or wedges or in circles. And they have to stand in front of the mirror and see for any dimpling of the skin or the lumps which may be so visible. And all of these simple illustrations will at least raise a suspicion in the woman's mind herself. And then she comes to you, then you can back it up and figure out by your clinical examination beyond the self-breast examination. So usually a mammography or a sonogram or an MRI will be used both for diagnosis and surveillance and the risk avoidance. Generally, the lifestyle advice is given, but it directly or indirectly impacts the overall well-being, but you cannot prevent it just by diet and exercise control. Tamoxifen and riloxafen are the drugs which they use as a preventionary precaution, and bilateral prophylactic mastectomy is sometimes done in a few cases where the oncosurgeon suggests the same. So the breast cancer experience is far beyond the breast tissue itself, because changes in sexuality and sexual desires, premature menopause, infertility, a lot of social issues like occupational changes, financial hardships, changes in relations with family and friends, and the mental and emotional changes. There is a lot happening around the issues of breast cancer, except that we need to encourage them positively for a better lifestyle to help them cope with this. So once again, we need to celebrate our survivors, and for that, an early detection and early action from awareness to action is what it is. We believe that if we act now, by 2050, everybody who develops a breast cancer will live if they are supported well enough. Last 2-3 slides, just to touch and go about the endometrial cancer, the inner lining of the uterus, the 5th most common cancer in the women worldwide. It's about 40,000 new cases every year with about 7,000 deaths. So not so bad, but still it can be detected early. And uterus, cervix, breast, these are the organs which can be, in fact, even the ovaries can be removed out of your system. So that means you're derooting the cancer if you detect early, and then you save lives. There is a strong association with the endometrial cancer and obesity, and therefore we are harping on that lifestyle. Here again, the early menarche or late menopause, infertility, obesity, treatment of breast cancer with tamoxifen indirectly influences the development of the endometrial cancer. Diabetes, which is a tsunami, and especially even in the age groups younger than 40 years, we have gestational diabetes going on to type 2 diabetes. And if they have a personal history of breast or ovarian cancer, they're also prone to endometrial cancer because the oncogenic genes, as I said. But overall, right from the start, if we encourage them for the more fibers in the diet, some things which everybody can do for a better lifestyle, and which causes increased estrogen excess, and the isoflavones, which is a fine way of replacement of estrogen, because these are phytoestrogens which have properties similar to selective estrogen receptor modulators. It's a simple thing to do, whether you believe it or not. The soy, the beans, the chickpeas, etc., which potentially they can modify the risk. So the symptoms of this is non-menstrual bleeding or discharge or very heavy bleeding. And if it has extended to the neighboring regions, then dysuria, painful intercourse, pain or mass in the pelvic area, weight loss, back pain, etc. So caution all your patients. about uterine cancer, that if there is an abnormal bleeding of any sorts, they cannot presume and assume that it is just some hormone fluctuations, they have to live with it, and this normally happens. No, they have to come for a checkup, and you have to check it out whether there are more ominous reasons for this. The new cases are rising, and more in the Asians, which are detected late and they have to lose their lives. And after menopause or in between the periods or post-coital bleeding, as we call, all of these need very, very special attention. So the diagnosis is not only by examination, but pap smears, endometrial biopsies, the dilatation in curettage, and of course, as the sixth sense of OBGYNs is the ultrasound, especially the transvaginal ultrasound. So treatment, of course, I said, early detection, the best option is to remove everything which is aligned to that system. The hysterectomy, salpingo-oophorectomy, lymph node dissection can even be done through the laparoscopy, radio, chemo, hormonal therapy. We always seek the help of our oncology colleagues, because every year the protocols are changing, newer advances are coming in. So may the best be done once you have detected. So the survival rates, if you pick it up in stage 1, there's a 90% survival. So again, we go back to the point, early detection is the best thing to do. So the precancerous hyperplasia, it's not yet gone into cancer, but it can, the excess estrogen can be countered by progestin, and the DNC can confirm whether it's going towards malignancy, and the few of them who develop untreated cancer can be detected early. So at the gist of it, we can say definitely that awareness plays a very, very important role. So talking to them, giving the visual aids, now there is so much. That's why the first slide started with a mobile, because there is so much on the WhatsApp university. Let the right messages percolate and pervade, and so much information on the social media that can be given. So the awareness and mass campaigns, we would urge each one of you to amplify it as a ripple effect, so that it just, the volume and the noise levels escalate, so that everybody is aware here, got to, take care. And because this are also something that are preventable, and early detection can also make a lot of difference. So we must pledge and say that together, if we move from awareness to action, we can have a handle and control the menace of the 3 types of cancers that I mentioned, which are very special to our gender. May the girls and women of this country be in the pink of health, thanks to all of you in your own capacity. If you move from awareness to action, we are sure to have a healthier generation and a prosperous country. Namaskar.
Thank you, Hema. Well, I am very, very passionate about disease prevention, and during our undergraduation, community medicine was something which we all took very lightly. And now the COVID pandemic has taught all of us that we need to concentrate on the preventable aspects also. So here, Dr. Hema, you have been speaking to an array of doctors of different specialities. You have a pediatrician, you have an oncologist, you have not necessarily an obstetrician. So a lot of take-home messages for all of us lady doctors. Yes, we have to remember that any lady patient that we meet, we'll have to remind them about breast self-examination, and we have to remind ourselves that ladies' checkup is not complete without a per vaginal and a per speculum examination. And scan just doesn't mean doing an abdominal scan. For a woman, as Hema put it, to check the endometrial thickness, we have to get a transvaginal scan also. And she also mentioned that in the outpatient department, we can, as in the OPD, we can still take care of prevention of cervical cancer by doing VIA, visual inspection after using acetic acid. Simple step that you and me need to do in the prevention of cancer. And of course, in the pandemic, we have realized the importance of not looking at the cost, because here Dr. Naveen has messaged about the cost of HPV vaccination. Well, it came to my mind that all patients took remdesivir injection in the black market. And so definitely that is a lesson to all of us, that the onus is on the patient and not on us. I'm not going to decide whether it's costly or not. So now there are 3 comments in the chat box as of now, and 3 more now. The first question what Dr. Naveen is asking is, the biggest barrier to HPV vaccination is the cost. What is FOXY and MOH and FW doing about it? And one more comment of his, comments on CA cervix in postmenopausal women. What percentage of CA cervix is seen in postmenopausal women? Is it usually diagnosed at a later stage? Because many women believe that they can't get it after menopause. Hema, you're muted.
In response to what the FOXY and the ministry is doing, unfortunately, we've been battling with the ministry, central ministry, for more than 15 years now, right from the introduction of the HPV vaccine in the country. And every time I used to be, madam, don't come here to sell your vaccine. So I said, no, sir, I'm not coming to sell the vaccine. I'm going. Then, they said we've made calls to 250 OBGYNs, and they don't seem to be believing that it is so worthwhile. So that's why I said the forums like these still are very important, because only 15% of our girls and women are covered with the HPV vaccine, even as we speak today. There's an immense scope to escalate, and now the costs have come down. Only 2 doses, if you give it to the girls, it's well within 5,000 rupees, or even lesser if you buy it in bulk and pass on the, the concessional advantage to the girls themselves. And there are many NGOs and organizations. It is for us to sensitize them that this is a useful cause. When they say adolescent care, they're always talking about anemia, deworming, lifestyle, contraception, life skills, and HPV vaccination. So if you have that, 330 million adolescents will benefit from this. And, in collaborative partnership, yes, we can find out the ways and means of reducing the cost, if cost we think is a barrier. But when we took a survey, 83% of them said that 2,000 rupees per dose per vaccine is quite okay. 83% said that it is quite okay, because we said only 2 doses and it's a once in a lifetime. So they were okay with that. So let's not be biased about the perception. And the MOH and the FOXY now in the last 8 years have recommended the vaccinations for the age group and in the dosages that I have just mentioned. So that much action has happened. Now it's for us to reach it to the girls and women. And about the late detection, menopausal women, see, they are obviously harboring, if she is menopausal at 48 and then she has a postmenopausal bleed, and that is why she has come to you and you have picked up a cervical cancer. This has not come in after her menopause. This is sitting there since the last 15 years. First of all, you could have vaccinated. Second of all, you would have done 3 early pap smear, you would have picked up the abnormal cells. In the recent past, HPV test also would have, picked up the, in that sense, an early detection. And certainly, the late diagnosis could have been avoided. Even in Ayushman Bharat and all, they're covering the cervical cancer treatment. But what we are telling the government is encourage vaccinations. Get the screenings in place. Then you'll have less and less women reaching you for advanced cancer care, where you're investing a lot of Ayushman Bharat money. Save that and put it where it is needed for prevention rather than for the care of advanced cancer. So that is the scenario presently. And I think the COVID has given us a good sense of courage to amplify our advocacy and noise levels with the government, that for women and girls, we really want this moving. So we are at it, Naveen. Yeah.
Dr. Dhanlakshmi's question is, what is the duration gap between vaccination to conception?
Okay. So if she's vaccinated today and she falls pregnant, in the next cycle itself, or in the next 2-3 months, then you know that at 2 months and 6 months for her next 2 doses of vaccine. So you delay that second dose until she delivers. So you don't have to start all over again with the 3 doses. So that is what it is, because at around 15 years to 26 years, we said you can, you will still need to give 3 doses. So if you take the vaccine, there is no need to cover with the contraception per se for the 6 months until she finishes the second dose. If she falls pregnant inadvertently, the dosages can be deferred to until after pregnancy, because theoretically in the modeling studies, even as late as 5 years it's been given, it has the same booster impact. So that is how it is. Yeah.
Yeah. Hema, again, Dr. Naveen's comment on lady doctors need to stress about prostate cancer prevention with doing the blood test. As also lady doctor, male doctors stressing on CA breast prevention by self-breast examination and pap smears and all that.
Yeah, this is a very correct societal question, because if a lady goes to a male practitioner, they may misunderstand that I have come for some other reason, and why is this doctor checking my breast? So it sends a kind of a wrong signal, if I may say so. So you have to just give them the posters, flyers, pamphlet, put, and say that for every woman this is really, really important. See, you can do it yourself. There are so many YouTube, channels which are giving gyan on this. So at least you start telling that, even if you don't examine, it's fine. If she has a concern and she comes back to you and tells you that, no, it looks like something, then you can always send her to your colleague gynecologist, who, if she's comfortable in that sense for examination by a female specialist, then so be it. So, but you have to facilitate this process instead of we ourselves shying away.
Yeah, Hema, a lot of appreciation to you for your talk, and I acknowledge presence of our.
Here in Canada, the vaccine is given in elementary school at the age of 10. That is our dream, Dr. Raj. That is really our dream. We are going to reach there very soon because the campaign is now getting massive. It's getting louder. We want, because even for rubella, we went the catch-up vaccine for rubella for all the girls. We went to massive, campaign in the schools, and we did cover them up. Now, of course, MMR vaccine, so rubella is covered for all the children in the primary immunization itself. But we had a phase where we had to run to the schools to give the rubella. So the same way, the HPV, if it doesn't get done, because it's a gray zone, she's neither with a pediatrician nor with a gynecologist. So that's the thing. So even in the school, it can be given in the school campus itself, because there are no alarming side effects of the vaccine. So it can definitely be offered. So the schools also be asking them to do a health tie-up with the insurance agency, so that for all the routine things, inclusive of obesity and such issues, they are comprehensively tied up. And through that agency, we are trying to make them aware that this is important. They can take it in the school, off the school, wherever. But that is a key. But government is not easily agreeable to this as of now, because this is not on their priority list, because they are again telling me, "Pehle anemia hatao, nahi to aap hat jao." So that is a kind of scenario, So it is a big battle, because for us in girls and women's healthcare, we go as great activists to campaign for our issues, but they have a lot many more issues, including nutrition, sanitation, supply chain, food fortification, malaria, tuberculosis, and whatnot. So it's a battle, but we have to fight it out. Yeah.
Yeah, Hema, one more question. Vaccination for boys. The transmission of the infection is from male partners. So what's your comment? Of course, vaccination for boys is recommended.
See, gender neutral vaccination, it's called GNV. That has already come up in Australia. Okay. But here what we are saying is, I had said in the first or second slide itself, that we have to look at everything with a gender lens, because women are denied. They are still looked at. We are in the metros and educated, empowered. We have a right to decide for ourselves. But it doesn't happen in more than 75% of our country. Even educated women in the north of India, they are not allowed to decide for themselves. So if we make it a priority for, gender neutral, then more likely that many boys will get it, the girls will still be denied. But like how the male contraception has not stood the test of time. There's only 1% undergoing the vasectomy. Why? It's a women's problem. She gets pregnant, and then all the risks are hers. It's nothing to do. So men participating in the contraceptive process beyond the HIV threat and the barrier contraception, the permanent method of contraception, it has not come into the forefront. Similarly, cervix is in the women. She is going to get affected. Finally, of course, there are the anal and penile cancers in the men, which are also partly contributed by the HPV. So first, 80% of our girls and women are covered. Then certainly the government can think of embarking on the public health measure of giving the boys also. But the gender neutral vaccination program, if that dream becomes a reality, HPV will be eliminated by 2030, 2050 for sure. Because then everybody is mass vaccinated, just like the polio example. Then that is, but we have a little bit of a journey to reach that point. Yeah?
Ima,
Patients will sell gold and property when they're sick to save their lives, but to prevent life-threatening diseases, but because this is my last comment, Anu, that if you are reluctant, they are reluctant. That's what I would like to say. If you tell with conviction, hey, this is good, this is really, because even vaccine hesitancy for COVID, even today, they're all in the villages and all, whole village are running away. They're not being available for vaccines at all. So if we say with conviction, without a clash, all the professional organizations have agreed, but we have to break the silos. If they go and ask an orthopedic, he said, maybe it may not be like that. So if everybody speaks with the same tone and tenor and the same voice, take it. Then there's no escape. They will take it. So I think slowly the preventive healthcare, the COVID has brought to the forefront. Let's encash on that. And when the COVID vaccine is going strong, the unfinished agenda of HPV also, this is the right moment for us to encash. Thank you so very much for this wonderful opportunity. I really enjoyed the afternoon. Thank you.
Thanks a lot, Hema. Any more questions in the chat box, or otherwise I shall pass it on to you, get them answered through you, and give back the answers. So I wouldn't want to intrude into the next speaker's time. So I immensely thank on behalf of all of us for your presence and for your good take-home messages in the prevention of cancer in women. Thanks a lot, Hema.
Thank you.
If time permits, kindly be with us. Yeah, thank you. So now we move on to the next agenda, and the next topic, as we all know, it is carcinoma ovary in women. And to give us more information about the next subject, we have Dr. Smita Saldana. She's an assistant professor in medical oncology in Kidwai Memorial Institute. As also, she is specialist in bone marrow biopsy also. And to introduce Dr. Smita Saldana, I welcome Dr. Ansuya. And before Dr. Ansuya starts off, I welcome our women's Bangalore branch women wing chairperson, Dr. Mamta, to say a few words because it's their opening webinar, and I am moderating the session on behalf of the Women Doctors Wing. Dr. Ansuya, your message. I'm sorry, it's not Dr. Ansuya, it is Dr. Mamta. She is very busy with her duty in Minto Hospital, somehow managed to steal time to address us. Mamta, are you muted? Mamta Matadi. Yeah.
Hello.
Yeah, we can hear you.
Hello. Yeah, thank you, ma'am. Good afternoon, everybody. It's my welcoming.
The network is weak.
Yeah, network issue.
Things to everyone, where everyone has grasped the things and we can implement the same thing to our community, ma'am. And it's also my pleasure to thank Dr. Anuradha Parmeshwar and also Dr. Vinay, making this webinar in a success way. Thank you.
I think Wi-Fi is working.
Can you hear me?
Hello?
Hello, ma'am, can you hear me?
Yeah, we can hear you, Mamta.
Yeah, ma'am. Thank you so much. And also thank the pharma company AstraZeneca too, ma'am. And it's my pleasure to thank more to Dr. Anuradha Parmeshwar to making this webinar as a great success, ma'am.
Thank you.
Thank you, ma'am. Thank you.
Yeah, thank you, Dr. Mamta. Dr. Savita, Chairperson for Women Doctors Wing, Karnataka State Branch. Would you say a few words? Dr. Savita? You can unmute and speak. Savita, we'll catch up later. We'll take her statement afterwards. Now, Dr. Ansuya, kindly welcome introduce Dr. Smita Saldana.
Yeah, good evening, everybody. I am Dr. Ansuya. I thank Anuradha Madam for giving me this wonderful opportunity this evening. I am having pride and privilege to introduce Dr. Smita. She has been the assistant professor in Kidwai Memorial Institute of Oncology, and she has completed her DMO in medical oncology in the year 2013 and 14 in the same hospital Kidwai, and she has done the fellowship in bone marrow transplantation, and she has got an experience of more than 7 years in medical oncology, and she's been expertise in treating various cancers like breast cancer, leukemia, lymphoma, multiple myeloma, GI tract and genitourinary system, head and neck and lungs lymphoma, and as Anuradha Madam told, she is also specialized in bone. And with ESMO, she has been a precipitatorship on metastatic and kidney cancer, and also on immunology to clinical application. And it was which was held in November 2018 in Singapore. And she's a notable recognition, and she has got very notable recognition and publications and many awards, including NITTE Education Award. She's been a gold medalist in the ENT the year 2000. And she has also acquired gold medal in community medicine in the year 2003. And she has been authorized in many national and international publications. And Smita, we are very happy to have you with us today, and we are eagerly waiting for you. And I heartily welcome with this bouquet, and welcome to you, ma'am. Over to you.
Thank you, Dr. Anusuya, for this warm words of welcome. And thank you, Dr. Anuradha, for this wonderful opportunity. So I think the prior speaker, Dr. Ima Bb Webinar, has wonderfully spoken about the 3 different types of cancer: breast, cervical, and endometrial. So I will basically limit myself to ovarian cancer. And let me just share the presentation. Dr. Hema already spoke to us about the breast cancer, cervical, and endometrial. Now it's very important to diagnose ovarian cancer early, because usually the stage of the disease matters for the survival and the prognosis. And in the recent times, you are seeing the incidence of ovarian cancer and breast cancer increasing. And what we see is most of the patients are diagnosed at the earlier or advanced stages. So I will briefly be talking on the various headings. So the introduction, the epidemiology and risk factors, the pathophysiology, in brief, the anatomy and pathology of ovarian cancer, the importance of clinical diagnosis, what are the symptoms the patient can come and how can we diagnose the ovarian cancer, the importance of BRCA testing. I think this is very important, and roughly on the management part. So if you come to the epidemiology and risk factors, ovarian cancer is said to be one of the 8th most common cancer among the females worldwide. It affects almost more than 3 lakh population. And if you look at the lifetime risk of a woman, it's almost around 1.4%. And they say 1 in every 72 women may develop epithelial ovarian cancer at some point of time. If you look at the estimated, the 5-year prevalence rate of ovarian cancer, it's around in 2018. This roughly tells us the what is the ovarian cancer prevalence. And this is India. It's not as much as what you see in the Western population. So the developed nations, the incidence of ovarian cancer is much higher. The other important factor in ovarian cancer is the mortality is very high in ovarian cancer. As the stage advances, the patients are not completely cured. We have advanced to a huge extent in the treatment of cancer. But certain cancers, in which when ovarian cancer is one population where when the stage is advanced, the cure rates come down significantly. The overall survival comes down significantly. The progression-free survival, that is the chance of, again, recurrence or relapse is higher, and the gap between the relapse is smaller. So ovarian cancer, if you see, has 7th highest rate of mortality and the 8th highest number of cancer-related death worldwide. So you can see here, the leading cause is breast, followed by lung. Then you have the colorectal, cervical cancer. The ovary comes around the 8th position. Now, in the breast, we have done a lot of advancement. We have newer molecules come up, newer treatment options come up. In lung, again, we have newer driver mutations identified. So the treatment options have improved. Colorectal, to some extent, we have had new targeted therapy. Cervical cancer, as already Madam has spoken, so I will not, there is the main stand of treatment is we are looking for early detection. Coming to ovarian cancer, again, it's important that we sensitize our primary care physicians and the person gynecologist that most of the patients will not be having any symptoms initially. They may just come with a routine complaints of fullness of abdomen or early satiety. So it's important that above the age of 50 years, they do a routine screening test, a routine imaging of the abdomen pelvis. So if you look at India, the Globocon 2018 data says almost around 60,000 new ovarian cancer patients we will have by the end of 2020. And by 2035, there will be almost a 55% increase in the number of ovarian cancer patients. So at present, we are at the number of 60,000. It may increase to almost 3.7 lakhs by 2035. That's a huge number. And the death rate also will increase by almost 67% to almost 2.5 lakhs they're predicting. So this is the data of 2018. And now as we see, the data shows more incidence of ovarian cancer in the urban population. Now, if you look at the risk factors, what are the important risk factors associated with ovarian cancer? The most important we know is one is the family history, where it's important if the person has a first degree relative with ovarian cancer. And here I would like to emphasize the role of BRCA mutation, BRCA1 and BRCA2 mutation. The other thing is the hereditary non-polyposis colon cancer syndrome, HNPCC we say. So these two are the most important mutations. Now, first degree relative, we mean either the siblings or the mother or the father. The grandparents will not come as first degree relative. So it's basically the parents and the siblings. Next, with the BRCA mutation, either BRCA1 or BRCA2, the risk of ovarian cancer increases by almost around 15 to 20%. BRCA2 related ovarian cancer will be seen more in the latter part of the age, above the age of 50 years. But BRCA1 mutation, they may develop ovarian cancer in the early part before 50 years itself. The other important thing is the reproductive history. In the reproductive history, what is important is we are looking for something called as the early menstruation, late menopause, because when you have an early menstruation and late menopause, the exposure to the estrogen is higher and they will have more of ovulatory cycles. So these ovulatory cycles, when they have more of incessant ovulation, they can have spontaneous mutations, and this can occur in the surface epithelium following each ovulatory cycle, and this can lead on to the onset of ovarian malignancy, we say. It's more in the fimbriated end of the fallopian tube. So also the increased levels of the FSH and the LH. So again, fewer pregnancies means nulliparities again one of the risk factors for developing ovarian cancer. The genetic predisposition, already I mentioned, the mutation in the DNA damage repair, that is the BRCA1, BRCA2, and HRD is something of newer concept, that is the homologous recombinant deficient pathway. That is basically, it helps in your DNA single gene repair. So this is important, that ATM, there's CHEK2, there is some other mutations which are important for the DNA damage. If there's a DNA damage, the repair mechanism, the double strand breaks. So if this is deficient, again, the chances of developing ovarian cancer are high. Then the postmenopausal obesity is one of the causes for developing ovarian cancer. And as we all know, as the age advances, every woman can develop ovarian cancer. Now, if you look at the incidence or the age when the ovarian cancer, what is the age group when you can see the ovarian cancer highest, it's above the age of 60 years. So roughly it's highest among 55 to 64 years, as this bar diagram shows us. Less than 45 years, it is usually less common. Most of the ovarian cancers are seen between the age of 45 to 84 years, and highest between the age around 55 to 64 years. If you look at the anatomy and physiology of ovarian cancer now, I already said what happens in each ovulatory cycle. There is a hypothesis called the incessant ovulation hypothesis, wherein they say there are higher risk of spontaneous mutations occurring with the repair of the surface epithelium during each ovulatory cycle at the fimbriated end of the fallopian tube. And this can lead on to the onset of a tumorigenesis and lead on to the ovarian cancer. Now, if you look, more than 90% of the ovarian cancers are epithelial ovarian cancers. You have the other subtypes, that is the stromal cell tumors, you have the serous carcinomas, and you have the germ cell tumors. More than 90% are epithelial ovarian cancers. And among them, the main subtypes are the high-grade serous tumor, which account for 71%. Then you have the low-grade serous carcinoma. You have the endometrioid, mucinous, and Brenner. In the stromal cell tumors, they are only less than 5% of all the ovarian tumors. And these are usually the good prognosis subtype. They usually will be diagnosed at stage 1 and are usually treated by surgery alone. They usually will not require any kind of adjuvant chemotherapy. Even epithelial ovarian cancer, if it is diagnosed in the stage 1A, then probably they do not require adjuvant chemotherapy. Germ cell tumor is a totally a different subgroup where the treatment is totally different. And there you have the subtypes like teratoma, dysgerminoma, choriocarcinoma. And choriocarcinoma usually is made with the post-pregnancy. Now, this is what the fimbriated end I was talking, where you can develop the ovarian tumors. Now, the main 5 subtypes of epithelial ovarian cancer are the high-grade serous carcinoma, almost 71%. The clear cell carcinoma, there's the 9.5%. Then you have the endometrioid carcinoma. These usually will be associated with prior history of endometriosis, around 8.3%. Then you have the low-grade serous carcinoma, around 4.4%, and the mucinous carcinoma. Now, the other entities, when you're speaking of ovarian cancer, the other common clubbing together is the primary peritoneal carcinoma. The primary peritoneal carcinoma and the ovarian cancer has a similar etiopathogenesis. So they are both treated as one disease. Now, if you look at the high-grade serous ovarian cancer, what are the various driver mutations which are important in the pathogenesis of the ovarian cancer? Usually, you have your BRCA1, BRCA2 mutations. So if you see roughly, the BRCA1 is more common, around 8 to 10%. The BRCA2 will be around 5 to 10%, we say. And the next, I said the HR deficient, that is the homologous recombination. So this homologous recombination, if I have to just speak a little more detail, basically every cell when it is dividing, there may be some amount of DNA damage. So if it's single strand break, usually our body will, there is a mechanism, the body is made such beautifully that there is a cell cycle check where if there's any kind of DNA break, it will be rectified immediately. When there's a double strand break, then it's important to have the role of your ATM and the CHEK2, the RAD51 genes, the pathway for the repair mechanisms. So when there is a homologous recombination deficient, It can happen when there is any of the CDK12 mutation, the RAD51C promoter methylation, we say, or the RAD gene mutation. So if any of these mutations are seen, it is called as the homologous deficient. And the significance of this is we have a newer molecule called the PARP inhibitors, which will act well in patients who are HR proficient. So that is why we are talking about this mechanism. So the other things are you have your P10 mutation, then you have your nuclear excision repair mechanism, and the major mismatch repair mutations. These are the other mutations which lead to the onset of ovarian cancer. Now let's just go in brief to the presentation. How will the patients present to us? So usually they present first to either the general physician or maybe to the gynecologist. Usually, most of the times, it will be referred to the oncologist only after diagnosis usually. So the patients with ovarian cancer usually have no symptoms or they have non-specific symptoms. And that is why we see the stage being diagnosed at a later stage. Most of the times the female, they may have symptoms of fullness of abdomen, or they feel distaste for food, or they feel early satiety, we say. That is, they may have a small amount of ascites, or the growth itself may lead on to this early satiety. And usually the lady takes it into saying that it is mostly gastritis. They do not go to the doctor immediately. And that is how it is missed. So most of the common stage symptoms are abdominal or pelvic pain. They may have vaginal bleeding, that is more in the endometrioid type of ovarian cancer. Some of them may have constipation. Abdominal distension is usually seen, but in the advanced stage. And some of them, they will have fatigue and urinary frequency. Again, if it's a single adnexial mass which is causing pelvic compression on the bladder, they may have more of a urinary frequency. The other, in advanced disease, they may have the increased abdominal girth, bloating, nausea, anorexia. They may have pleural effusions, usually the right. They may have dyspepsia, respiratory symptoms like breathlessness because of the pleural effusion or the abdominal distension, early satiety and difficulty eating, abdominal or nodal mass. So most important thing is when the elderly women, a postmenopausal women comes to us saying, complaining of either nausea, vomiting for a long duration, or if they say early satiety, that is usually after taking a small amount of food, they are saying they're not able to eat more. Or they say they have suddenly noticed an increase in the abdominal girth, then we need to evaluate. Now, it's a simple test which will require most of the malignancies of ovarian can be diagnosed on the ultrasound abdomen itself, abdomen pelvis. So you can simply get an ultrasound abdomen pelvis. You don't have to get a CT scan upfront. So usually postmenopausal women, when they come to you, if they have any of the symptoms for a long duration, do not take it like just a simple GERD or a gastritis. Please investigate. Now, ovarian cancer will be diagnosed. You have to have a physical examination is important, and your imaging, that is ultrasound abdomen pelvis, or further you require a CT scan abdomen and MRI, and the tumor markers. Now, usually CA-125 is a screening test, but it is not very significant because it is not a specific and a sensitive test. It can be even raised in the other conditions like pregnancy, ovarian cyst, a benign ovarian cyst, certain benign inflammatory conditions. So it's not very sensitive and specific. But a very high value of CA-125 with any of the symptoms in a postmenopausal woman indicates you to do a further testing. So the first thing is physical examination. It's very important you do a physical examination, a complete per abdominal examination followed by a per vaginal and per rectal examination, because the initial deposit may be only in the pouch of Douglas. In this, you may either see a ascites, and the pelvic examination, you may see a deposit. Next, the imaging, you can do a transvaginal ultrasound. This is done for the very early stage of ovarian cancer or for a screening in high-risk patients. Then the most important thing what we routinely do is an abdominal and a pelvic ultrasound. So ultrasound is a very good and sensitive test to detect an abdominal lump or mass. So if there is a solid abdominal mass in the ovarian mass, it has papillary projections, and then areas of hemorrhage, it indicates more in favor of a malignancy. Then you do a CT MRI scan to confirm your diagnosis if you have seen by ultrasound. And the tumor marker, you always do the CA antigen, cancer antigen 125. Some also do the CEA levels, because CA 125 by CA levels, they say more than 5 or less than 5 is more indicative of a ovarian cancer, but it is not specific. So both the ESMO and the NCCN guidelines recommend the use of physical examination. In the imaging, it's usually the ultrasound abdomen itself and the CA 125 assessment for the diagnosis of ovarian cancer. So you don't need to get a CT scan imaging upfront. Now, what is the next thing is there any role for screening? So in screening, I said you, in certain cancers like breast cancer, cervical cancer, you have very good screening modalities. But for ovarian cancer, we do not have a good screening test. There are two tests called the transvaginal ultrasound and the CA 125, but both of them are not accurate and not specific. The transvaginal ultrasound is an instrument which uses sound waves, and it creates an image of the uterus, the fallopian tubes, and the ovary, and that is used through the ultrasound through the transvaginally. It is important or useful for detecting if a mass is present. Very in the early stage, or a patient with a very high risk features like BRCA1 or BRCA2 mutation, above the age of 35 years, till then you can do the transvaginal ultrasound in such high risk individuals. It is not routinely recommended for all the general population. The CA 125, again, above the age of 50 years, you can do if the person has any symptoms. But again, it is not a specific or a very sensitive marker. So currently, as per the ESMO and the NCCN, there are no guidelines which recommend the use of screening for ovarian cancer, except for patients who have the family history of BRCA mutations or the HNPCC mutation. If ovarian cancer you're suspecting, next what will you do? A sample of the tumor is very important for us to know confirm the diagnosis and to plan our treatment. So we know in ovarian cancer, the very important thing is the staging of the disease. And if the stage is early, they tend to do better. The prognosis is good. The overall survival is good. If the stage 2 and above, the prognosis significantly falls down and their chances of recurrence increases significantly. So when you're doing a tissue sampling also, it's very important that you do not overstage the disease. That is, it should not cause a spillage of the tumor to the pelvic cavity and cause upstaging of the disease. So the techniques used to obtain a sample for the suspected tumor is either you can have an image guided biopsy, that is CT guided or ultrasound guided, or you can do a laparoscopy or laparotomy. If these are not possible, you just, most of the patients will have ascites. Anything above stage 1C will have ascites. So here you can just take ascitic fluid, do something called as a cell. If you do ascitic fluid analysis, cytology will see malignant cells, but it is not enough for us for our treatment, because we need to know if it is an adenocarcinoma or if it is a serous carcinoma or it is endometrioid carcinoma. Not that it makes a difference in our treatment options, but it makes a difference in the prognosis and the further management. So when the ascitic fluid is there, you can do a cell block, and in the cell block, we can do the IHC for the specific subtype of the epithelial cancer. A chest X-ray always to know the staging of the disease. So routinely, these are ultrasound abdomen is also a must. So when you're staging the disease, always you have to get the basic either a CT scan abdomen pelvis and a chest X-ray for early disease. Because if you have seen the disease is spread to other than the outside the pelvic cavity, then it becomes stage 4. Then your intent of treatment of changes. It changes from curative to palliative. So it's very important. And most of the time, if you think the person has advanced disease, we usually go in for a PET CT scan because it tells you the whole body imaging. Now, what does the ESMO and the NCCN recommends? So NCCN recommends that all the patients with suspected ovarian malignancies should be referred for evaluation by a gynecologist, gynec oncologist. They should undergo a comprehensive surgical staging or biopsy for any bulky stage 3 and 4 patients. And the type of surgery should be based on the suspected disease stage. So if it's an early disease, that is stage 1 or stage 2, the person can go in for an upfront cytoreductive surgery. But any stage above advanced, stage 3 or stage 2C and above, usually they incorporate the role of neoadjuvant chemotherapy. So we give neoadjuvant chemotherapy wherein the disease bulk comes down, it downstages the disease, and then you can get a better complete cytoreductive surgery. And when you have a better complete cytoreductive surgery, the overall survival increases significantly. The chances of recurrence falls down significantly. So it's very important in ovarian cancer that the emphasis is on the complete cytoreductive surgery. So following the confirmation of ovarian cancer, as I already said, the extent of the disease has to be determined. So the stage and the grade of ovarian cancer is usually determined. And for this, you require to get a ovarian tissue biopsy. Just with the FNAC or just with the cytology, it will be not able to determine the grade of the cancer. So for staging, it usually refers to the size of the tumor and how far the cancer has spread. So if it is limited to the ovaries, it is usually stage 1 or 2 ovaries, it is limited to stage 1. If it is confined, it has spread beyond the ovaries and is limited within the pelvis, it is the stage 2. Stage 3 is when it is gone beyond the uterus and beyond the pelvic cavity. And stage 4 is when it has spread to distant organs like the lungs, the bones, or the liver. So stage 4, usually the intent will be usually palliative. But any stage above stage 2 to stage 4, we will usually start with the neoadjuvant chemotherapy. And the usually standard practice is we give a platinum with a paclitaxel, 3 cycles, and then take up the patient for a cytoreductive surgery. So it is mentioned here, staging is a powerful indicator of prognosis, and therefore it influences the treatment options, because as the stage of the disease increases, the outcome reduces significantly. Next, grading is also important because it tells us to what extent the cancer cells resemble the normal cells. So grade 1, it is a low grade, so the proliferation is little lesser. Whereas the high grade, it is more of the mitotic potential is very high and they're very fast growing. So grade 3 indicates poorer prognosis, grade 1 indicates better prognosis. So this is the schematic diagram showing you the stage 1, stage 2, stage 3, stage 4. So stage 1, as I told you, it is limited to 1 or both ovaries. Stage 2A, when the disease is beyond the ovary, spread to the early pelvic cavity. Here the cancer, stage 2C, the cancer cells are spread locally and also to the fluid of the abdomen. That is, if there is cells in the ascitic, then it becomes stage 2A. Now, other important is stage 1C. Stage 1C, cancer is on the surface of the ovary and they can have positive washings, but this becomes stage 1. Stage 2A will be when it is spread to the ascitic fluid, and stage 3 when it is spread beyond the uterus and beyond the pelvic cavity outside. You have lymph nodes involved. Stage 4 when it has spread to the other organs, either maybe the lungs, the liver, or to the bones. So next, let's just talk on the genetic testing or the BRCA testing, BRCA genes. So why it's important to test the BRCA status in our clinical practice? So I think this importance of BRCA came with our Western Hollywood actor Angelina Jolie. There was something called the Jolie effect. So her mother had diagnosed with breast cancer, and when they did the mutation testing, she was found to have a BRCA mutation. So then subsequently, these children underwent the mutation, and that Angelina Jolie underwent the testing, and she was also found to be positive for BRCA mutation. And she underwent a risk reduction bilateral mastectomy and the salpingo-oophorectomy. So with that, I think the knowledge of your genetic counseling, the BRCA mutation came more into the public open forum. And with the advent of newer molecules, the importance of BRCA mutation also becomes more important. So it's important for us as a predictive factor or for the treatment of these patients. So women with ovarian cancer, you require to do BRCA testing because it can tell us a subgroup of patients who are more sensitive to a particular chemotherapy-based treatment and who can be targeted with the PARP inhibitors. So the PARP inhibitors, you have various drugs like the niraparib, olaparib, and the rucaparib. Olaparib and rucaparib are available in India. Next, the prognostic factors. BRCA mutation status is an important prognostic indicator. So along with the stage of diagnosis, histology, and the extent of surgical debulking, it tells us how this patient can do, how will she proceed forward, what is the chances of her overall survival, what are the chances of her relapse. So we can keep the family prepared, we can keep the patient prepared. Next, if the person, there is an index case of ovarian cancer, if we do the BRCA mutation and we find that she has a positive mutation, then it helps us in doing a risk assessment for her further first degree relatives, that is her children or her siblings. So that will help us to do the risk assessment for patients who have BRCA mutation. So when you're doing BRCA mutation, it is not indicated for all the patients. If a lady has breast cancer less than the age of 45 years, or a triple negative breast cancer less than the age of 35 to 40 years, a lady having both breast and ovarian cancer less than the age of 45 years, having a family history of a male breast cancer, having a history of a first degree relative or an aunt with both ovarian and breast cancer in the same individual. These are some of the factors where you have to require to do the BRCA testing. So when to test and whom to test. So the guidelines recommend that for all the patients of ovarian cancer, you should test at the time of diagnosis. But unfortunately in India, so far we were not doing the diagnosis at diagnosis, the BRCA testing, because it was a very expensive test. It used to cost at least around 25 to 30,000 earlier. Now with the advent of the pharmaceutical companies, them supporting, the testing is done at a lesser cost of around 10 to 14,000. And now the incidence with the awareness, the testing has increased. So all the guidelines, the Australia, France, Germany, Italy, all of them say you should do the testing at diagnosis. So if you have a patient, it's better to do the testing at diagnosis for a ovarian cancer patient, because you can risk stratify them, you can know their prognosis, you can know what are the outcomes, you can give them the targeted therapy. So next, in what do you do the testing, the BRCA testing? So once you diagnose the ovarian cancer, in the tumor, once you remove the sample, either the biopsy sample or after the cytoreductive, the entire specimen, you do the BRCA1 and the BRCA2 test on the tumor. This is called the tumor test or the tumor BRCA mutation. If it is positive, it indicates that the tumor has the BRCA mutation. Then the person undergoes genetic counseling, and then you do a BRCA1 and BRCA2 germline test. Now this is done either through the buccal mucosa or through the blood. The tumor test is done on the tumor per se. The germline test is done either through the blood or the buccal mucosa. And if this is positive, again, genetic counseling is required for the entire family, and the familial considerations come into play. So just because the tumor has a positivity of the BRCA mutation does not indicate that it is a germline mutation. It may be just the somatic mutation in the tumor. If the germline mutation is there, then it indicates the importance of genetic counseling for the entire family members and doing the familial testing. Next, coming to the treatment options. So the treatment pathway for patients with both early and advanced ovarian cancer is relatively similar. Only thing is, for stage 1 ovarian cancer, it is usually surgery, followed by, if it is stage 1A, you don't require adjuvant chemotherapy, but 1B and above, you usually give adjuvant-based chemotherapy. So surgery will be usually total abdominal hysterectomy, bilateral salpingoophorectomy, and you give them platinum-based chemotherapy. For stage 1C and above, you have to give platinum-based chemotherapy with or without a maintenance bevacizumab addition. Now, stage 2 to stage 4, usually upfront you give neoadjuvant chemotherapy, and neoadjuvant chemotherapy usually we give the paclitaxel carboplatin. Usually it is given either as 3 weekly cycles or it is given as weekly cycles. If the person is not fit or if the person is very frail, and usually when the stage 3 ovarian cancer or stage 4, we see that the person is general condition is not very good, the performance status is not very good, we go in for something called as the weekly reduced dose of paclitaxel carboplatin. We give for 9 weeks, reassess them, then take up the person for cytoreductive surgery. And in cytoreductive surgery, the goal is to get a complete cytoreduction. So it should be minimal, as there should be complete cytoreduction is very important, because that is improves the outcome of the patient, improves the overall survival, and also prevents the recurrence. After that, you give adjuvant chemotherapy, complete your adjuvant chemotherapy. If you are given 3 cycles earlier, you complete another 3 cycles of the paclitaxel carboplatin, usually minimum of 6 cycles of adjuvant chemotherapy is given, followed by, in high risk patient, we can give the maintenance therapy with bevacizumab. If the person has any of these mutations, what I spoke on, BRCA mutations, then you can, in certain cases, high risk cases, use the PARP inhibitors. Next, we all know as the stage of the disease advances, the person will come back with the disease sometime. They will relapse. It may be 6 months or 1 year or 18 months. So it's important that the recurrence-free interval is longer, or the disease-free interval is longer. As the disease-free interval is longer, the outcome of the disease improves significantly. Then again, if the patient comes back to you with disease recurrence, you give systemic therapy and followed by a maintenance or observation. So in the recurrent ovarian cancer, anything above stage 3, stage 2 and stage 3 usually will come back to you with a disease. And yes, very important to know the platinum response. So we classify into 3 groups. If they're platinum sensitive, platinum resistant, or platinum refractory. So this has generally been defined as a time since the completion of the first line platinum based chemotherapy. So if you have given the patient has been diagnosed as ovarian cancer, underwent cytoreductive surgery, and then you have started treatment from today. For 6 months, you give 6 cycles. So roughly it takes around 18 to 21 weeks. So roughly it will be around 5 months. And within that duration, if the patient comes back with the disease, it becomes a platinum resistant. If it comes back after that end of the treatment, if the patient comes back after 6 months with the disease, it becomes a platinum sensitive disease. The cancer recurs more than 6 months after completion of the initial platinum based chemotherapy. Platinum resistance, when the cancer recurs within the 6 months of completion of the initial platinum based therapy. And platinum refractory is during the chemotherapy itself, the patient has progressed with the ovarian cancer. So here, why we are telling this importance is, in a platinum sensitive, the most important drug which works in ovarian cancer is a platinum. So if the patient is platinum sensitive, you can re-challenge the patient with again a platinum backbone. If the patient is platinum resistant, you use a different molecule like maybe etoposide or a topotecan or a liposomal doxorubicin. And again, when the patient becomes platinum sensitive, you re-challenge with platinum. For a platinum refractory, they usually must be having some driver mutation. So you need to find out what the driver mutation is and target it accordingly. So in brief, the NCCN guidelines tells you for all the stage 2 or to 4 patients, you do the imaging, stage the disease appropriately. Post that, in stage 2 to stage 4, you can use a bevacizumab-based therapy for high-risk patients. Look at the BRCA mutations, if they are germline or somatic. And if the patient is in a complete remission or partial remission, you can use either do observation or use niraparib. If the person has a BRCA mutation, after a complete remission or a partial response, you can use olaparib. Niraparib is still not available in India. So we have olaparib and rucaparib available in India. And if you have used bevacizumab as initial maintenance, you can continue bevacizumab with olaparib, or you can continue olaparib alone. So the sponsor of today's, one of the sponsor, AstraZeneca, they have first launched the molecule of PARP inhibitor olaparib, and they have come up with the attractive patient assistance program also. So many of our patients who are BRCA mutation positive are benefiting with their molecule called Lynparza. So the ultimate goal for us, for clinicians, is cure in ovarian cancer. But unfortunately, the cure rates are very small. Only 15% of stage 3 and stage 4 will survive for more than 10 years post-diagnosis. So because of this very poor survival rate, it's very important that we try to diagnose them early and give them a better treatment option or better maintenance treatment. And then the role of your targeted therapy comes. Unfortunately for us, our treatment options are not covered by the government, specifically in cancer. The Ayushman Bharat or the Vajpayee Arogya Shri scheme we are still in the basic level of only paclitaxel carboplatin. Your targeted therapies are not covered on the Ayushman Bharat or the Vajpayee Arogya Shri scheme. So the treatment options are there, but it's very expensive. So the cost of 1 month therapy of PARP inhibitor is roughly around 3 lakhs. If it is not supported, with support, it will come to around 1.5 to 1.7 lakh. So for a general middle class family or a general person, it is very difficult to afford these treatments. And even if you're saying your VEGF inhibitors like bevacizumab, even these do not come cheap. Even they are roughly costing around 30,000 to 40,000 per month. Next, the progression rates, even the optimal surgery and the first line chemotherapy, despite the best treatment, still 70% of women will relapse within the first 3 years. So again, the maintenance therapy is important to them. And it's important we have some therapies with less toxicity and less, which will give us add on more years to the life with lesser toxicities and a better quality of life. So in the last 5 years, we have seen various advancements in the cancer management. We have the advent of immunotherapy, the targeted therapy. When I was doing my DM, I never thought that we will be using so much of targeted therapy or so much of immunotherapy at present. So, but now we are trying to reduce the usage of cytotoxic chemotherapy in the advanced diseases and going for more of targeted therapy whenever we have this driver mutations. So you have the advent of pembrolizumab, olaparib, niraparib, rucaparib, and various other molecules which help in the maintenance of ovarian cancer. So coming in about the final slide, the decision-making consideration what we take for ovarian cancer is, the importance is the stage of the disease, the efficacy of the drug. And while efficacy, I say always, if the patient has an advanced ovarian cancer, always go in for neoadjuvant chemotherapy with your most common drug, the paclitaxel carboplatin. They will have some side toxicity, but it's usually well tolerated. And if the patient is frail or not fit enough for going for aggressive chemotherapy, you can go with the weekly regimen. Next is, it's important for us to know the various mutations, the important germline mutations of BRCA, BRCA1, BRCA2, or the HNPCC, and the HR deficient pathway. And if these are there, familiarize the patients for the targeted therapy. So in summary, the ovarian cancer is the 8th most common type of cancer worldwide and the 7th most common cancer of mortality. There are several types. The most important, 90%, is epithelial ovarian cancer. The diagnosis of ovarian cancer is usually delayed because of non-specific symptoms. For any postmenopausal woman who comes to you with symptoms of early satiety, some GI disturbance, please get an ultrasound abdomen pelvis done. Usually it is specific to diagnose the ovarian cancer. And you require to undergo a complete physical examination, imaging with a CT scan, a staging, and a CA-125 evaluation. A biopsy is always a must before you start the patient on treatment. And treatment is usually with the platinum-based chemotherapy. For patients with high-risk features or genetic mutations, please go in for a maintenance therapy with targeted therapies or PARP inhibitors. So I'll stop my talk and I'm open to take any questions.
Yeah, and Dr. Smita, there's a long question in the chat box. I would like to read it out. So many young girls and women suffer from PCO, PID, and endometriosis, often producing pain and pelvic masses. As the incidence of these diseases are increasing, are more gynecological malignancies occurring in the young being missed? So he is asking for correlation between.
See, actually, endometriosis, pelvic inflammatory diseases, PCOD does not have a correlation to ovarian cancer. So as I said, what is the one correlation for ovarian cancer is your ovulation. The more number of ovulation it happens, there is more chances of having that damage, and that may lead on to the chances of having ovarian cancer. The other thing is, because at present your nulliparity has increased, the pregnancies have reduced. These we say pregnancy is actually it got a protective effect, because when during pregnancy, during lactation, the chances of anovulatory cycles are more. So that itself, the amount of exposure of the women for lactation, specifically in the urban area, is less. So that may be one of the factors for development of ovarian cancer. But pelvic inflammatory diseases and endometriosis, we have seen that there may be an increased incidence of endometrioid type of ovarian cancer, but per se people having endometriosis do not have more ovarian cancer.
Then Dr. Hemlata's question, any biomarker test available to do screening to predict ovarian cancer?
As of now, unfortunately, still we have not come up with a very good screening modality for ovarian cancer. So I said, CA125 is what we are using it, but it is not a specific and a sensitive test. But I think in the postmenopausal women, we routinely do it and see if it's a rising titers. We get along with your symptoms and abdominal ultrasound, you can correlate and do it. It's more of a clinical history taking and the pelvic examination, which is more important with the ultrasound.
So Dr. Smita, you have been, yeah, Dr. Naveen wanted to say something.
Dr. Smita, I think you didn't understand my question. What I understand very clearly that there is no association between PID and PCOD and endometriosis and cancer. That was not my question. My question is, we have young girls coming to us, 20, 25, and they sometimes have symptoms which could be very non-specific, like GI symptoms, etc., etc. And many times these symptoms are like patients who have with accompanying dysmenorrhea. They have vomiting or something else. They have those symptoms, and we very often misinterpret that, thinking that it's just part of that. And when actually you're dealing with a cancer which you're missing. Yeah. And that's why, I had a patient, a very young patient, who still haunts me today because I knew, her diagnosis was delayed and she lost her life.
No, I agree. I took the question in the other way around. Okay.
So, Smita, it's very clear from your presentation, after your presentation, of course, you have a general crowd here of all specialities. It's not just the gynec or just the general practitioners. All of us are there. And I'm very happy to share that male gynecologist from Canada is also with us. Dr. Raj is with us. He's my classmate in BMC. And Pan India also, we have a lot of other seniors from Indian Medical Association as well as from the Women Doctors Wing. So we were given to understand that there are no specific symptoms for ovarian cancer, and general symptoms also are we are likely to miss. So we need to be focused and investigate it and catch them as early as possible, isn't it?
Yes, ma'am.
Yeah. Yeah. So now
what happens is we see patients with advanced cancer, and most of the time what happened is they would have neglected thinking it is just a GI symptoms, and therefore they come to us with a very advanced disease. And when we see them in the advanced stage, no matter what you do, still they'll have a very bad survival.
Yeah. So when the symptoms don't respond, the patients also have a tendency to change doctors. Right. So the second doctor takes time to analyze. By that time, they would already gone to the third doctor.
Yes.
So now what I'm asking you now is, yes, GI symptoms or other vague symptoms we shouldn't ignore. And as Dr. Naveen put it, young or old, all of us, we have to take with pinch of salt. No question of neglecting. Now you said that there are some special group of patients whom you're going to channelize and make sure that you don't miss out. So I want you to summarize on that to the practicing clinicians. For example, what you told us was BRCA, which are the group to be targeted.
So BRCA mutation, as I said, it's very important to take a family history. Now, with this effect of, I said, the Jolie effect, a lot of people who come to you, many of the young women, even if a simple breast lump or simple problem, they'll come and say, if they have anybody history of family, any history of cancer in their family, they'll immediately come to the gynecologist or to oncologist saying, check if I have a cancer, do a testing. So it's not indicated for everybody. So if the person has a family history, if the individual per se develops personal history of breast cancer at the age of less than 35 years, a triple negative breast cancer, we say, that is the hormone negative type, or a history of a breast cancer and ovarian cancer less than 45 years of age, they have a first degree relative with a breast cancer and ovarian cancer less than 50 years of age, they have more than 2 or more primary breast cancers, the first being diagnosed less than 50 years of age, they have a family history of a male breast cancer. That is usually either their father or their sibling, some male has a breast cancer. And these are the individuals where the chances of having the BRCA mutation, harboring the BRCA mutation is higher. And these patients should undergo the BRCA mutation testing because it is not an inexpensive test. Earlier days, we were not doing it for everybody, but presently we are doing it for most of the people because we have assistance. The costing will be around 15,000, 10 to 15,000 for the BRCA mutation.
Yeah.
And the other subgroup is Ashkenazi Jews. So we do not see them over here. So that I will not tell. Those people are at a higher chance, higher number of BRCA mutations are seen in this subset of the race.
Yeah. Yes, Dr. Smita, that you have been giving us a good presentation and good. We are happy with your answers also. Now, thanks, Dr. Vasanta, for logging in. And her question is: in rural areas, we often see abdominal hysterectomy with oophorectomy, and your comments on that.
No, I mean, this is for, you're saying it in terms of routinely being done for like fibroid or for bleeding. Yeah. So see, again, I normally abdominal hysterectomy and oophorectomy above the age of 45 years, I think is fine. But lesser than that, we have other, when the ovaries are remote, the estrogen level is low, the early onset of menopause. So there are other challenges which the person will develop, the other physiological changes. But yeah, definitely when the ovaries are removed and the hysterectomy is done, the chances of developing uterine cancers or ovarian cancers or even a breast cancer, because we say estrogen is the one of the most important hormone factor or driving factor for breast cancer, reduces. So those may reduce, but they will have other onset of other menopausal symptoms. And even if the person has a BRCA1 or a BRCA2 mutation, or a person is there is a chance of her developing, she has the somatic mutation for developing ovarian cancer, it can still develop in the primary peritoneum. So I said primary peritoneal carcinoma and ovarian cancer are one. So the common tumorigenesis pathway. So even if the ovaries are removed, still the person can develop a primary peritoneal cancer. So even in a BRCA mutation patient who is having a BRCA mutation, this high risk hereditary gene, the risk reduction, what we do is prophylactic mastectomy and risk reduction bilateral total abdominal hysterectomy, bilateral salpingo-oophorectomy. But it does not say 100% the person will not develop cancer. They can still develop a primary peritoneal carcinoma. So it definitely gives some benefit, but not 100% benefit.
Again, I think, Dr. Smita, you need to specify on the medical legal issues also, because you need to speak to the patient, tell them about the advantages and disadvantages of retaining or removing the ovaries. So in that way, when you're in dilemma, you tend to leave one healthy ovary and after adequate counseling.
So yeah, important is if the family is completed. I forgot to mention that. So it's all fertility is preserving. So if the family is completed, then only you go for the risk reduction or the complete total abdominal hysterectomy and bilateral salpingo-oophorectomy.
Yeah. Then Dr. Naveen, you talked about routine abdominal scanning at the age of 50 for cancer screening. Is this an accepted recommendation for cancer screening in routine population? Maybe in the 45 to 50 year high risk.
So as the NCCN or your ASCO recommends, for ovarian cancer, abdominal ultrasound is not mentioned as a routine screening method. The transvaginal ultrasound and CA125 have been tested, but again, they have not shown us, it's not very specific and sensitive. So only for the patients with the high risk population, the patients who have the BRCA mutations or the hereditary mutations, we do this more often, the CA125 and the transvaginal ultrasound. And once they complete their families, they're going for the risk reduction surgeries. But for routinely, I did say, because it is at least for India, I feel we can do it because you can detect the onset of ovarian malignancy by ovarian ultrasound. You don't have to go for a CT imaging immediately. But it is not the routine or the standard screening method. For ovarian cancer, still we do not have a standard screening test.
So if at all there is something called screening, it is the BRCA testing for high risk individuals. Yes. And so now there are no more questions in the chat box, and we are running out of time. And so the question to you is, when are we going to utilize your services in the prevention of CA ovary? In the sense, you need to tell us, reiterate again that some high risk groups have to be sent to you for the testing. If the BRCA testing were to be cheap and easily available, I think we all would have misused that test by now. So kindly, once again, let us know exactly how we need to channelize the patients, and I think we need to refer to you for an opinion.
So if a patient, like most important here will be a family history. So if the young individual comes to a gynecologist or to a physician with the symptoms of any kind of suggestive of cancer or asking for a cancer testing, and if they have a family history, a strong family history, that is at least more than 2 types of cancers in the first degree relative. So first degree relative, I mean the mother, that is the parent, either of the parents or the siblings. So, or the children. These all three will come as the first degree relative. So, if the mother or if there's a male breast cancer in the family, in the first degree relatives, or if they have an aunt who has two types of cancer at the age of less than 50 years, both the breast and the ovarian cancer, or if the personal history, she herself has had a history of a breast cancer less than the age of 35 years, then these are the populations who may be at a very high risk, and these may require to come to oncologists to get the further testing done.
Come to the oncologist, no.
Oh,
Refer
no,
to the oncologist.
Yeah.
Isn't it? So we have to...
So we are always referring, we are always the tertiary center. So always you will be referring to us. So it's primarily seen by you, madam. You all are the people who do the first, most important and the wonderful job. We only see it at the end of the thing and then we are managing it. But so what is important is if they come to you earlier, they confide in you earlier, then probably we'll be able to see a reduction in the incidence of early diagnosis of the cancer. Most of the women, what happens is they do not come to the doctors, they do not open up. That is what we see.
Yeah, I agree, Smita. As in the COVID era pandemic, we lost a lot of people, doctors and non-doctors. And the simple basic reason was lack of monitoring. The doctor, when his saturation came down to 65, when asked, he had not monitored his SpO2 at home at all. So also, what we need to do as a preventive aspect, I think we have to concentrate more on that, particularly now that the health awareness has improved tremendously, particularly so for our country. So certainly we have to utilize the service of the consultants, though the gap between you and us should be further reduced is what I have to say. And Smita, no more questions in the chat box before. Thanks a lot for your wonderful presentation. And any other question, I'll get back to you for the answers. And before Dr. Satyavati, our chairperson, co-chairperson, is ready for delivering vote of thanks, I want Dr. Savita, chairperson, Women's Wing, Karnataka State Branch, to say a few words, and also Tejas, representing AstraZeneca, who have been the company which has backed us up for kickstarting our Women's Wing webinars. I would like him also to say a few words. Dr. Savita?
Yeah. Good evening, everyone. Myself, Dr. Savita Ramesh, Chairperson of Women Doctors Wing. Very happy that Women Doctors Wing, under guidance of Karnataka State Branch Headquarters and Karnataka State Branch, we are, I'm a headquarters and Karnataka State Branch, we are doing really well. And our Karnataka State Branch 5th month webinar will be on cybercrime, and we'll shortly let you know the date and time about it. And this is Bangalore branch's first Women Doctors Wing webinar. And I'm really very happy and thankful to Dr. Anu ma'am and for her, guiding and supporting us in this. And hearty congratulations to Dr. Ima Divakar ma'am and Dr. Smita Saldana, who have given a wonderful presentation regarding carcinoma in women and carcinoma ovary. Thanks a lot to both of you, ma'am. And once again, I'm very happy to inform you all that there'll be a 2-day webinar series on safe motherhood journey tomorrow and day after, that is 5th and 6th July, between 6:30 p.m. to 8 p.m. I kindly request all of you to log in, and you all are welcome. Please kindly log in, and it'll be a very informative session. So do kindly log in large numbers. Thanks a lot, and thanks a lot for allowing me to speak few words. Thanks everyone once again.
Thank you. Tejas, thank you, Savita. Tejas.
Hello, ma'am. First of all, I would like to thank ma'am. First of all, I would like to thank the IMA Women Doctors Wing actually for providing this opportunity to have this cancer awareness program as such. And it's been a wonderful time, that because at this point of time, as all the doctors mentioned, it's utmost importance to diagnose the patient at the earliest, so they would get a chance of cure and also having a better outcomes from the treatments that they would be allowed to have. So in that regards, creating this awareness, as Dr. Anuradha madam mentioned, the overall purpose of this is also to have probably a channel wherein actually you will diagnose it at the earliest. Like the patients would actually reach out the family physicians and the primary care centers specifically at the early. So if they get an understanding and to refer them to the oncologist at the right time, they get the best outcomes coming through. So that was the overall intent also, to have this awareness programs running through. And thanks for this opportunity to collaborate. And I would like to thank Dr. Smita ma'am to help us out with this particular wonderful talk for us, and also to enlighten and create more awareness on BRCA testing, which is actually one of an important aspect which is coming through to diagnosis and probably have a treatment outcomes be better with the new advents of PARP inhibitors coming through. So in that regards, I would like to thank Dr. Anuradha madam to help me out in actually having those smoothened process also to have this particular session here, ma'am, and all the IMA members, Women Doctors Wing members also on that.
Yeah, thank you.
I thank you, Deep. Thank you, ma'am.
Yeah, I acknowledge the presence of all our senior IMA, right from top to from north to south, having logged in and supported us, as also Dr. Raj from Canada, male obstetrician, my classmate too. And sincere thanks to each one of you, Dr. Padmini Prasad from BSOG, the present president, Dr. Vasanta, then all other senior doctors from FPA, as well as from BSOG and IMA. And special thanks to Dr. Smita for a wonderful presentation, and also to Dr. Hema. Definitely our outlook to seeing women patient is going to be better tomorrow when we go back to our OPDs. Thank you. And Dr. Satya, our Women's Wing co-chairperson.
Thank you, madam. I'm honored to deliver the vote of thanks to this informative webinar. I express my gratitude to the Indian Medical Association and its very active Women's Wing, with a special thanks to IMA Bangalore branch and the Women Doctors Wing, who have put the first step today in conducting the webinar and will continue it every month as per convenience. I thank Dr. Srinivas, our main pillar of support in all our activities. I thank our dynamic president, Dr. Vinay, for his encouraging words. I also thank our chairperson, Dr. Mamta, who is always enthusiastic about the Women Doctors Wing activities. It's a great pleasure to thank Dr. Anuradha Parmesh ma'am for her yeoman services to the academic development of many doctors through interactive webinars. She plans every step meticulously, involving all the EC members, and very inspiring with her untiring energy. Thank you, ma'am. I thank AstraZeneca Pharma India, who have associated with us for this webinar. I thank Dr. Ima Bb Webinar, who has given us the much needed awareness regarding cervical cancer and vaccinations. I thank Dr. Smita Saldana, who gave us an elaborate explanation of ovarian cancer. And a very special gratitude to all the doctors who have taken their time on a Sunday to attend the webinar and has made it an interactive session. Thank you.
Satya, AstraZeneca and John.
Yes, madam. John also. Of course, I cannot leave him at all. Thank.
Yeah. Thank you. Thanks, one and all. Bye.
Yeah.
John, close my.
Thank you.
Thank you.